Hello, my name is Mike Whitaker. I'm a consultant in the Division of Endocrinology, Mayo Clinic, Arizona. And I've been asked to briefly summarize my talk regarding male androgen replacement therapy in very few minutes. From the clinical standpoint, the most important question to be answered with potential hypogonadism is it there or not? And if it is there, why is it there? So the first question, is it present or not, is contingent on classic signs and symptoms: reduced libido, erectile dysfunction, mood changes, loss of muscle mass, all of that taken together in conjunction with appropriate laboratory measurement, which includes an 0800 testosterone level first thing in the morning on repeated occasions. The goal being to try and identify a clear pattern of low testosterone on a number of occasions at 8 o'clock in the morning. If that is present in conjunction with symptoms consistent with the diagnosis, a diagnosis of hypogonadism can be made. The next question is, why is it present? And to that end, the next step would be to measure an LH and an FSH. The testicles themselves being at fault, there's a number of conditions that can cause primary hypogonadism. That results in low testosterone and a high LH and FSH. If, however, it's secondary hypogonadism where the pituitary is at fault, you're going to see a low testosterone with either a normal or reduced LH and FSH. If it's secondary in nature, the next question, why, and the list for that is very long. You need to rule out the possibility of cellular tumors, cellular problems, prolactin levels, thyroid function needs to be checked. There are a number of drugs that can interfere with the pituitary, and narcotics are notorious for that. Sleep apnea can present with a picture of low testosterone, low LH, FSH. You need to be particularly cognizant on that one because if present, you do not want to treat with testosterone as it will exacerbate the sleep apnea. Obesity and diabetes give a similar sort of picture. So the next question needs to be addressed: is it primary or is it secondary? And you need to go as far as necessary to pin that down. And that may include cellular imaging to rule out the potential for tumors. Once you've identified a presence of male hypogonadism and you've identified a potential cause, the cause is treated. If no cause is identified with extensive workup, treatment is warranted, and there are several preparations that can be used. The most popular are going to be the testosterone gels. Testosterone injections work and work very well indeed. Less popular means of testosterone replacement includes buccal, testosterone administration, or testosterone pellets. Before starting therapy, a PSA needs to be checked with digital rectal exam. You need to keep an eye on a PSA 3, 6, and 12 months after starting, and yearly thereafter with a digital rectal exam. And you need to follow the hematocrit because a rise in hematocrit to greater than 54% can occur with testosterone and would mandate discontinuing it. Testosterone therapy can be instituted and continued largely indefinitely so long as you're following from the prostate standpoint, following from the hematocrit standpoint. And that very briefly is what we are looking for. Is it present? Why is it present? And once that's determined, start appropriate therapy and follow up.